Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. In today's video, we're going to dive into a more complex case. This is a patient with a non-union following a prior TTC fusion. This patient presents with the additional challenges of poorly controlled diabetes and Charcot arthropathy, which makes the management obviously much more difficult. In addition, she develops a non-union and some broken hardware, which is really challenging when it comes to managing the non-union. In this 16-minute video, we're going to talk through some of the nuanced steps that require safe removal of the failed TTC fusion rod, talk about how to address the non-union, all while accounting for the patient's multiple medical comorbidities. If you're a medical sales rep and you're covering these complex cases, this particular case will help highlight some of the insights into managing the decision-making and achieve a successful outcome. Hope you enjoy. This is a patient, this is from a few years back, so we do have a little bit of follow-up on it, and she is in her early to mid 60s, diabetic that is not well controlled. And this is how she presents to clinic. And so I've shown this case before, mostly just because it's scary to me, but was managed in a boot and put in a boot, and not necessarily different than I might have managed this patient, and comes back for a routine follow-up at 1 week with saying her pain and swelling is a little bit more noticeable. And now she looks like this. And then you get a CT scan and it looks like this. So maybe first off, Jan, what are you telling the patient at this time? Obviously, now the fracture is a lot more significant than we saw initially. Maybe it was something there and we just didn't pick up on it. I couldn't see it. I've scrutinized those x-rays multiple times. I don't think I would have gotten a CT scan in this case. But, maybe this is a warning that if you have somebody comes in that's a brittle diabetic, that's A1C is 11, this is why we ask about those things.
Yeah, absolutely. This would get me wake me up during clinic, right? This would get me going. Seeing these x-rays, you would think it was fairly routine based on the first x-ray set.
Yeah, yeah.
But I'm thinking, yeah, neuropathy, Charcot. I am really zoned in on that right now. And if I didn't at their first visit, I'm really looking that up and, asking those questions or finding that information. One of the screening tests I always ask patients who are diabetic, I ask, what's your hemoglobin A1C?
Yeah.
And if they don't know their hemoglobin A1C, chances are they are a poorly controlled diabetic. So, yeah, but this is one I'm thinking limb salvage situation. It's not open yet, but other things are going on with this patient.
Yeah, this is one that this scared me a lot because that initial set of x-rays, I like to think I'm pretty tuned in on things and would pick up on something. I might have managed this the exact same way, boot, if it was stable under stress, weight bears tolerated, but it now anymore, if I have a diabetic, especially if they're above, I don't have a great threshold. I know we say 8, 9, 10, but they have dense neuropathy, for example. Maybe that's the more important test. And they come in with that case. I'm thinking more and more about whether or not I need a cast in that situation.
What type of cast are you using?
Well, if I'm doing it for something because I'm concerned that they're going to go into Charcot, I'll put them in a total contact cast. Now, that's not always an option. So even just a regular, short leg cast, but I don't know. Are you thinking long leg cast in that situation, or are you thinking more total contact?
I was thinking total contact and just out of curiosity. So do you guys do that in your own office? Do you have to send them somewhere?
We
What
have it in
logistics?
our office. Our cast techs are good. We're in Tennessee, so they deal with some diabetes, and so they have been trained on how to apply a total contact cast. But it's a good point that that's not always an option, and you have to be trained in ability to do it. I personally couldn't do a total contact cast. I have
Right.
people that help with that. How about you? Are you guys doing it in your clinic or?
No, not in our clinic. We do have our PT wound therapists will do it, but they're in the same building as me, which is nice. However, it's not like I can get if I see a patient this today, I can't get a total contact cast today or tomorrow. I
Yeah.
maybe next week. Sometimes they can squeeze them in on Friday, but it's logistically more difficult to get.
Yep. Yeah. Okay, so you're managing this how? I mean, this is maybe quick, big picture because this isn't even the discussion to be had, but how are you managing this?
At this point. So, making sure, get a medically optimized hemoglobin A1C. You can't change the hemoglobin A1C, but I give them the riot talk about, getting their diabetes under control, assuming they have diabetes. And then I'm a big fan of, I'm not going to plate this. I'm going to nail this, with a retrograde like hindfoot nail. And, I do that almost routinely for some pilons and for these types of injuries now.
Yeah, and I think the point being that this isn't one that I think you can salvage, right? It's not like you can, meaning like you can't go in and just fix the distal tibia or the distal tibia fracture now. You have to do something to the joint because the bone quality there is going to be so poor. I've had some like almost this insufficiency like picture where they're a little bit, I can think of one patient in particular that had something just a little bit more proximal to this, but also was like not diabetic and probably had something else going on that we never really diagnosed, but was otherwise like healthy person that developed these stress fractures. And in those cases, I was able to go in and salvage it and almost do like an osteotomy and open it, but I had more bone to work with. There's nothing left in
Yeah.
that in
There's
that
that shell. Look at that,
with the shell.
sagittal view. I mean, yeah, there's this joint's gone. I
So
like
this is
it.
what you got. Yep, this is what we did. Maybe could have argued I should have taken out more of that medial, the medial tibia there because I left a little bit of a bump. But I was trying to avoid also my skin incisions in this particular setting and was trying to keep it relatively minimal. And so we did a TTC fusion right out the gate. You can see I put some bone graft in. I think this is one in which you've kind of coined the term the biologic kitchen sink. So kind of throwing several things at it to try to really get some healing. I probably spend most of my time on the tibiotalar joint as opposed to subtalar joint. I did prep it and curette it out, but I'm also not wanting to totally strip it either. How are you approaching these, Jan?
Yeah, so same way, I do the tibiotalar joint first, and I think it's probably a lot easier just to prep. Maybe I'm more used to it. The subtalar joint, I will usually first get my starting point before prepping the subtalar joint. If I will get my starting point and starting reamer, because I'm afraid to prep the joint first and then do the starting point because there's too much motion in the subtalar joint. I feel like there's more motion that way. So I get my starting point, starting reamer. I then prep the joint and then place the nail.
So you put the reamer in and leave it and then go back, or
I just had the guide
oh,
wire
you have
through
the
the
guide
nail.
wire in there, and then you use that to control it, or you just want to make sure you know where your start point's going to be.
I know where my start point's going to be. So it's already done. So like I know where the nail's going to go. And it's for me,
Oh,
it's just
oh, oh, oh,
easier
oh.
because
Okay.
when you try to mobilize the soft tissues around the subtalar joint, I think you create a lot of motion in the subtalar joint, and it's harder then to get your starting point when multiple things are moving.
Got it. So that's interesting. So my partner, she will put like a lot of wires around, like, multiple Kirschner wires or pins, 2 millimeter pins to kind of stabilize everything. So she'll line it all up and put them outside the plane of where she's going to go just for that purpose, to try to stabilize it. But I have to ask if she does the subtalar joint first. I always do the subtalar joint first and then just hold
Oh,
it.
really? That's
Yeah,
interesting.
but
Yeah, I do it last.
that's an interesting point. I've never really thought about that, and I think that's a good tip, actually. All right, so we do the TTC fusion. I think we're in good shape. She kind of
It looks
always
great.
felt and heard. Yeah, I was like pretty happy. Tibio-talar joint looks like it's got good bridging bone. Questionable on the subtalar joint, but I don't know if I really cared that much. But you look at the tip of the nail and you look at my distal screw, and if you look kind of in this area, you can kind of see there's a little bit of a halo in that space. So probably should have been more concerned. She didn't have a ton of pain, which is maybe one of the blessings and curses of your, Charcot and neuropathy. But now look at the nail. Look at the bend. That bend is not supposed to be there, unfortunately, as much as I want it to be. And you look at my lateral and my CT that I got, you can see there's not much going on in that subtalar joint, and there's a big windshield wipering across the talus. So now what do you do, Jan? Non-union subtalar joint. She's painful. She hurts.
Yeah, it looks like, she's healed the tibiotalar joint, right? I
That's the
mean,
good part.
that's
Yep, that part looks
so
great.
you got 1 out of 2. I think you're
Yes,
batting 500 here. So that's yeah, it's a World Series. You got to
better than
be
Aaron
happy
Judge.
here. Yeah. So I still get a CT scan in this type of case to further, even though I know the subtalar joint's not healed, I just want to make sure there's no surprises in the tibiotalar joint. And then, I'm taking this out. Obviously, that there's sometimes difficulty in taking broken
Yeah,
hardware. you got to have everything available here, hooks, different trephines, you name it, you got to be ready for it. And then renailing this to protect the tibia, and also then putting some, maybe, I don't know if I would use screws or a plate here, around the nail distally for the subtalar joint. I'm not sure. I would have to gone back and forth because it can be very difficult. I had a patient today in clinic actually that, you know, I, if you already have a tibiotalar fusion, the rate of subtalar fusion subsequent, so getting the subtalar, if you don't get it fused the first time, is very high, the rate of non-union. In some
Yep.
studies, 40 to 80%. That's a
Yep.
huge range.
Huge range.
So, you're not even, it's worse than flipping a coin.
Yeah.
So I don't know, so I'm thinking I've had a couple in my career, and one I got to fuse and one I'm still dealing with. And I don't know if it's what fixation construct might be the best there for just for the subtalar joint, because you got success in the tibiotalar.
Yeah, and that is a little bit frightening to hear and a little bit encouraging at the same time, because your point is well made, that we talked about like different types of non-unions, and then sometimes I think of those as being around fractures, but there's a nuance to managing a non-union when you're talking about like fusing a joint. And this is one of those areas that are really high rate of failure because of that fused tibiotalar joint. Plus, not to mention all the other comorbidities she's dealing with. So here's her X-ray and her CT scan,
Man,
and you can see non-union hole. And then I should have included an axial of the calc on the here to show you what bone you have left, because this is where you get into a challenge. And one of the things, this may be a little bit of a soapbox, and let me go back and just make sure before I say something. You see where my nail sits there on the mortise? See how it sits a little bit lateral? On these straight nails, I think you have to sit a little lateral in the talus in order to make sure that you're actually in the heel. Because I've seen some non-unions occur, myself as guilty as anybody, where I probably am too medial on the calcaneus relative to things. Now, you've shown some cases before, I think about one of your TTC fusions that you put on ortho bullets where you used a valgus nail, and that helps protect you from that, I think, a little bit. But in the straight nail, you have to make darn sure that you are actually in the heel, because I've seen that be a reason for failure in these cases. And then to your point, do you have enough bone left in the calcaneus to do a nail? Okay, so Jan, so we're taking her for a revision. And what are you bringing out for instrumentation to get this nail out?
yeah, I think you got some of the tools there, right? You're using
Yeah.
everything to get that end cap out. I'm using the broken hardware set, the Winquist set as well, which has a lot of nail removal, not only trephine's, but things to, you can go basically cross thread the broken part of the proximal segment of the nail and pull it out like you would, routinely. This is everything. This is like I'm booking this for a few hours. Not expecting to have a early day doing this. Sometimes it comes out easy and you get lucky.
Right.
And if worse comes to worse, what I've done before, you can go from the top down. So you can get a tibial nail start point and hit it down from the top.
Yep. Yep.
So in the same way, or you can hit it up. It's hard to do that through a tibia, go up. You can do that through a femur, but in a tibia, you can go top down and try to hit it down through the heel if you needed to.
And then one thing that I've learned the hard way is, you obviously got to make sure all the interlocks are out, right? But
Yes.
one thing that what you want to do is you don't want to lose the interlock, because sometimes keeping that nail, and it's probably not going to spin at this point, it's pretty secure in there, but I put a freer. I'll just like take the screw out and I'll put a freer in that hole, so that if I'm trying to thread into that nail, it's not going to spin on me. So it's not like a spinning construct. There's obviously the Winquest screw removal set. There is, what's the screw removal set?
Shukla. There's
The
the Shukla.
Shukla. They have a nail removal set as
They
well.
do. It's very
And
good.
and I think that's been a good option. So if you're a rep, and you have one of these cases coming up, you can always like reach out and help facilitate getting some of these constructs. So I was able to get something threaded in. I've had cases with this nail where I wasn't able to, and I got a hook just lucky, got a hook into there and got it pulled out. So that's one option that you can do as well. What about, as they talk about threading guide wires into the nail. Have you done that? Stacking guide wires?
I've done everything. I've tried everything. Not everything has been successful, but you're right. So in terms of the guide wire, what Nick is saying is you put a small guide wire in first, like a 2.0 or something from like a small nail, and then you take a bigger guide wire and you incarcerate it in the nail. So there's two guide wires, so it's incarcerated, and then you're able to sometimes even put a slap hammer around those two wires and take it out, and it gives you control of the nail again. And it can work. I mean, you got to bring everything in the toolbox to these cases because you
Yep.
don't know what's going to work.
Yep. The one I've tried on this, and I don't think the cannulation is big enough, is but to insert like the ball tip guide rod in and then, get it up past and then slide something underneath it. I've seen that described for other nails, but I think they're mostly tibial and femoral nails where you have a little bit bigger cannulation that you can get something
Right.
all the way down the canal. Okay, so luckily, honestly, this went much better than it should have, but was able to get something to instrument reverse thread into the nail and obviously get it out. And then I was able to get in there. I used a burr and a curette, so I used the MIS burr and prepped the joint, and then packed bone graft. This is Thank you. It came together really well. It had enough bone that I felt like you can see my axial there, that felt like I was in bone. I had a CT scan kind of showing the same thing again, to the point being over here. I'm kind of in that lateral aspect of the talus. That's kind of where I expect to be in this particular case. And then used a couple misanail screws or whatever we want to call them to kind of supplement fixation across the subtalar joint, and kept her off it for like a year. It probably felt like a year. And then this is our final follow up at, I think this is probably 8 or 9 months post op, and felt pretty solid. I don't think I repeated a CT scan, but clinically she was doing well. So,
The last couple ones that I've done like this, where I've had to like miss the nail and so forth, and in a revision situation, I've tended to use beams as opposed to just cannulated screws, just for some added strength because these
yep,
patients tend to be diabetic,
yep.
obese. I don't, they, the two I've done it on recently have gone on to heal. I'm not saying it's because of the beam, but it does make it more rigid, for your construct.